Well, good afternoon, everyone. It looks like uh, folks are really joining us now, and I want to welcome you and thank you all for joining the third session of our 2025-26 Informatics Talks. This year, we're excited to host various presentations with a focus on AI and informatics, and including today's speaker. So please spread the word with any of your friends and colleagues. But before we get started, if we can have the next slide. Next month, we on January 22nd, we'll be highlighting the work of one of our senior clinical informatics fellows, Dr. Peter Zhang. So stay tuned for more information to come. But we really look forward to yet another exciting talk after the new year. Next slide, please. As you can see, we are offering continuing medical education credits today for this session. If you wish to claim those credits, just simply text DBHi and the number 1 to the phone number you can see on the slide, and you will be automatically given credit for today's session. Next slide, please. We do ask just a few logistics for today. Ask that you mute your microphones during the presentation. There's also live captions available if you would like that. There will be time for Q&A at the end of the presentation today. So in order to prepare for that, please feel free, jot down any questions at any time in the chat, or if after the presentation you'd like to unmute, please just use the hand raising feature and we'll recognize you and take your questions. And so at this point, I'm really very honored to introduce to you today's speaker, Dr. Stephon Proctor. Dr. Proctor received his PhD in clinical psychology from Penn State and master's in biomedical informatics from the University of Pennsylvania MBMI program at the Perelman School of Medicine. He is currently an associate professor in clinical psychology at Penn and practicing psychologist in the Department of Child and Adolescent Psychiatry and Behavioral Sciences at CHOP. So really, we're just so pleased to have him join us. But not only does Stephon hold clinical board certifications, he was one of the first recipients of the informatics certification through the AMIA Health Informatics Professional Board, the HIP certification. So here at CHOP, Dr. Proctor is the Associate Chief Health Informatics Officer for EHR and Platform Innovation, where he leads all efforts related to innovation, including clinical AI efforts, which we hope to hear more about during his presentation. He also leads our Provider Builder program. He's really an outstanding educator in informatics, is the go-to person for many of us who are looking for mentorship and expertise in the EHR. So Stephon is recently, he's actually very nationally known with numerous presentations at AMIA and EPIC, UGM, XGM, and I think probably one of the most active persons that I know on the EPIC user web and other social media and informatics. So please check him out in cyberspace. But besides being dedicated to building intelligent systems that improve care delivery, Stephon's real expertise shines in applying AI, workflow engineering, and data-driven design to reshape how healthcare teams interact with technology. So today, Stephon will be exploring CHOP's journey to integrate generative AI tools into everyday workflows to enhance efficiency and user satisfaction. The title of his talk is Towards a Playbook for Implementing Generative AI in Healthcare. So I could go on and on, but without any further delay, let's all welcome Dr. Stephon Proctor. Thanks, Stephon, for being here.
Thank you, Tony. What a fabulous introduction. I'm honored. Let me switch to taking over. All right. Can someone confirm that they can see the slide deck before I put it into presenter mode?
Yes.
Yes.
Good.
Great. All right, let's make this. Okay. Still see it, right?
Yes.
Yep.
All right.
Looks good.
Great. So I'm going to start off with the faux pas. I changed my title before, shortly before this, but I actually do think this is a more accurate descriptor of what I'm going to be talking about today. So even though I'm going to be talking on our journey to implement AI here at CHOP, I really want to give a special thanks to everyone that was involved in this. It really takes a team to do all this, and this was not all done by me, but I'm really going to be summarizing those efforts. All of these people and any of those I forgot are really the humans in the loop for the type of work that I'll be discussing. So I've always wanted to be one of those presenters that had a disclosure slide with tons of financial disclosures to really show just, how much money they were making or how important they were into the field. Unfortunately, I don't have those, but I will go over some other disclosures that are more relevant for me. So I have no financial relationship with Epic or any AI companies. I will be talking about Epic, but my only relationship to them in a formal capacity is that I'm a vice chair of their behavioral health steering committee, which I've been on for the past 6 or 7 years. That is an unpaid position, by the way. I also will be using generative AI for a lot of the photos and images that you see on this presentation. You'll also see QR codes in the top right of many of my slides, which are, in my opinion, a better way for me to share the links to things like publications or news articles. To make sure I'm having fun while doing this, I'm going to be using humor sparingly. And my first is that the plants that you see behind me, these are in fact real. Many people think this is a background. I'm very good with plants, and this is proof of that. So Tony did a really great introduction, so I won't go over, the details of like who I am or what makes me qualified for this, but I do want to highlight 2 aspects of my identity that I do think help facilitate this work really well. As a psychologist, one of my primary jobs is to understand humans and their behavior. And as an informatician, it's really important for me to learn the technology and how that impacts healthcare. And when we're bringing technology such as AI into healthcare, it's really helpful to have the benefit of both of those identities to bear, because we really need to understand not only the technology, but understand the people that are going to be using them. So I'm going to set the stage by first talking a little bit more about Epic. Many of you know that this is the EHR that we use here, but you may not know just how dominant they are within the EHR field. They have an incredible market position with about 42 hospitals and about 54.9% of beds in the US health in acute care using the EHRs. They win over most new contracts for EHRs, and there's not much competition between them and some of their competitors there. They're in many countries besides the US, and in their EHR, about 325 million patient records are represented. On top of that, they have a huge financial war chest that they can use to further their technology further. And the reason why I bring this up is because of their huge market share, what they choose to do with implementing AI is actually going to affect many hospitals, because that's baked right into their product right there. So you really can't talk about AI in the healthcare space without knowing who's behind that system. So when I was preparing for this talk, I was curious about when was Epic first showing some interest in integrating AI, because this wasn't always something that was on their roadmap. The earliest publication I could find was in February of 2021, when their founder, Judy Faulkner, was giving a seminar. And what she had said was, at that time, they're about 2 years away from releasing artificial intelligence components into their EHR. And the example that she had given was the AI listening to a conversation between a clinician and patient, or drafting orders or plans of care. And then about a year and 9 months later, the world started to become aware of ChatGPT when it was first launched and announced by Sam Altman of OpenAI. And then, true to form, about 2 years later, Epic had formally announced their partnership with Microsoft to bring OpenAI's latest model, GPT-4, into the EHR. So now it was official. Now I want to set the stage for where Epic is planning on going with this. So they have a roadmap that they make readily available. And so here's an example of many of the features that they have available now. And you don't necessarily need to see all the examples there, but they cover everything from clinical workflows to patient-facing applications and also operations. This is things like analytics, also rev cycle. So I reached out to them and I said, well, what else do you have further? What's beyond your roadmap? And they gave me what's available next year. And then they also gave me what's available later. In total, this is 131 features and counting. When we first started doing this work early on, there were about 61. And this list is growing. So I'm going to be talking about generative AI, but I really want to kind of set the stage for where this fits in with other clinical decision support and AI existing currently in the system. So you may have heard of rules-based AI, and it's just the way that it sounds. It's building systems that are rule-driven so that you may give the system criteria to say, if this happens, then we want the system or the user to do that. Oftentimes, this is what you're seeing in something like an OPA or an, what's formerly known as a best practice alert. Then you have predictive AI. This is using a variety of variables in the system and statistics to help predict certain outcomes. This can be outcomes such as the likelihood of a patient being readmitted to the hospital, the likelihood of no showing, and so on. And really, the remainder of my talk is going to be talking about generative AI. And this is a form of AI that, simply put, is used to generate new content. An example is this slide. I use an generative AI product called Napkin AI, and it's really good at creating images for your drafts, for your presentations. So now let's talk about the promise of generative AI. What is Epic and the field in general saying that AI is going to be able to do for us? Well, I'll use an example from my work. One of the main ways for me to help patients with their problems is to listen to their stories, for them to come and talk to me about the struggles, the pain points, the problems that they or their family are having. Prior to using AI tools, I would often have my laptop on my lap and I'd be feverishly typing away, trying to make sure that I documented everything for their story and making sure that I had everything met for compliance, billing, and other aspects of my documentation. And this was really getting in the way of that connection that I had with families, but at the same time, it was really the only way that I could make sure I efficiently documented that record. Well, now we have technologies where when I'm meeting with a family, I can use something called an ambient scribe that is listening to that conversation and helps me document that story in a synthesis and helps me draft that note. And not only that, it can take the contents from that note and generate a patient visit summary that describes what happened and what are those next steps in language that the patients can understand. So in some ways, we've removed that laptop out of that as a barrier between me connecting with the family so that I can spend more time connecting with them and then also provide them with materials that they can understand to follow up for those next steps. Now let's talk about another use case. Generative AI is really good at synthesizing and identifying information, especially the wealth of information that we have available in our electronic health records. And unless you actually worked with an EHR, it's hard to really conceptualize just how much data there is in the system. So what you're seeing here is an example of what's called the chart review activity. So think about the old days when you had a big paper chart. This is like the digital embodiment of that. And on the left side, you have what are called your tabs. And in your tabs are different pieces of information. Encounters are bundles of information about when a patient was seen. But you can see across the top, you have a list of tabs. Not only do you have the encounters, but you have notes, labs, imaging, you name it, it goes from left to right. There's a lot of information there. And it's really hard to have the time to prepare for that. So I thought what I'd do was show you an example of what it looks like to go through all of those tabs. All right, jokes aside. So what AI is able to do now is various technologies that some of them that we're piloting and some of that we've implemented is have the AI go through many of those areas of the chart and summarize that for you. Some of these AI have become so sophisticated that they can look back 3 years worth of notes and provide you a succinct and organized summary of that patient's history and what's happened in between. What's really helpful then is this is taking the time that it would take for a human to do all of that. And we're also finding that it's bringing forth information that many of these users would not have found because they simply didn't have time to look for that information across all those tabs. But now I want to talk about some of the challenges that the field and also that we're having with implementing generative AI in healthcare. So I'll first talk about what's called the model layer. So when we're implementing AI, you have kind of two simple layers. You have the model that underlies everything. This is what is often the technologies that you refer to as the model for ChatGPT. And then what I'll talk about on the next slide is the application layer, what Epic has built on top of that. But the underlying model, really the brains of the AI that is popular right now is ChatGPT. So ChatGPT 4 was released only 4 months after they initially released 3.5. And then 14 months later, they released what's called their multimodal model. So this one was more powerful. It could not only handle text, it could handle images, uploaded files, and even audio. So it makes sense that it took a lot more time for that to be developed. But here's the surprising thing. Since then, on average, new models have been released about every 4 to 5 months. It's incredibly fast in such a short span of time. And if you've been watching the news, as little as this week, OpenAI announced that they're going to have a new model. They chose an interesting name, Garlic, for it. But what's spurring this is that there's a lot of competition between different companies because Gemini or Google came out with a new model last week. And so now each of these companies is racing to release new models. That's a challenge for us because as we're using these technologies, the underlying technology below them is updating very frequently. And there's huge differences often between these models. Now I want to talk about the application layer. And this is what Epic builds on top of that model. And this is what you as a user are interacting with. An example is ART, or Augmented Response Technology. This was introduced by Epic in 2023. And simply put, it uses AI to help draft responses to patient messages. And there's an example there. So what we were finding is the pace of their development for this was changing even as we were piloting it and after that. So CHOP went live as one of the first organizations to go live enterprise-wide with in-basket drafts. But then what started to happen was they added new features. So they allowed messages to be drafted for proxies, which is really helpful in a pediatric institution because you may have messages coming directly from the patient as well as their caregivers. Then they added the ability for the messages to sound more like the provider by using past messages from that user to inform how the AI sounds like the user. Then they started to add other features like using the AI to help flag when there may be some urgency about the patient message that was coming in. Then they started to add the ability for the AI to try to identify the categories of that message so that it could more intelligently route a message for scheduling differently than it may route a message for medication refill. Then more recently, they changed the underlying infrastructure so that the AI was smarter to handle messages that often have 2 to 3 questions. What previously Art was doing is it may only choose one of those, but then it would ignore the other ones because it wasn't sophisticated enough to handle multiple questions. Well, starting actually this week, it can handle more of those in one message. Now, the AI can also look at your recent assessment and plan so that when it's thinking about how does it give a recommendation to a family, it's giving the recommendation based on your last note. We're also starting to explore Art for drafting messages when a new result comes in to really help explain it in a way that a patient can understand, and then save the physician time in responding back to the patient. They're also looking at ways of grabbing information from elsewhere into the chart and adding that to your summary view. So not only are you going to be able to review the message that the AI has drafted for you, but it will grab some insights from elsewhere in the chart so that you don't have to dig for that in time to respond. Finally, what they're hoping to do is to bake in protocols. Even at CHOP, we use many different protocols for how you're supposed to respond to a message. That in the future will be added as well. And who knows where this is going. So I wanted to give an example of what this feels like in practice. So I recorded our team rolling out these features. And really what I'm trying to illustrate here is just how quickly that underlying ground beneath you is changing as you're trying to keep up with these technologies. Now I want to talk about AI regulation. The FDA has approved AI in specific formats, and it's only been for medical devices. But as of yet, the FDA has yet to approve generative AI. So what that means is the generative AI use cases that are being used in healthcare actually have not received any FDA approval. This is something that they're still grappling with to try to figure out how to do so. But as of yet, the FDA has only been able to approve medical devices, and generative AI is not yet defined as a medical device. The other aspect is that AI is readily accessible. Every one of you has the ability to have AI models in your mobile devices in your pocket. So that means if an organization hasn't even given access in a certain way to ChatGPT, it doesn't matter. Users can still use that to inform clinical decisions. They can often then become reliant on this or come to really expect that this is something that they need to have to help with their healthcare decisions. And the problem is, of course, there's not much oversight of that or appropriate training for how to use these technologies. Simply put, this technology for the first time is one of those technologies that many people had even before it was formally implemented by an organization. So now let's talk about some trust and safety aspects. AIs, as many of you know, are prone to hallucinations or confabulations. This is by design to allow them to have some creativity in their responses, but there's often times where they're still inaccurate, and they're confident in this. Now, if you're drafting an email, it's not a big deal, but in healthcare, the risks are much higher. We also know that the data that goes into training these models has biases, and then that can then perpetuate into the healthcare setting. And there are research studies that have documented findings of finding things like gender bias or racial and ethnic bias in medical uses of AI. We also have the black box problem. And essentially what this means is that with AI, you can't ask an AI how it knows what it knows or why it answered in the way that it did. It'll confidently give you a confabulation and say why it did that, but it's often not accurate. This is where the field of explainability or explainable AI comes in, where they try to add a middle solution to help understand why the AI made that. But in a lot of healthcare applications of AI, we, even on our implementation team, don't have direct access to how the model was designed or why it's providing, say, a draft the way that it did. Then, of course, we need to think about who's responsible. Is the AI company responsible? Is the vendor responsible? Is it the user? Well, according to Johns Hopkins, they say the AI is to blame. They say the clinical user using it is. And then finally, we need to think about automation bias. Because these AI systems are so easy to use, because they sound so confident, it's often easy for people to overly trust them and to really depend on them without taking a second guess on the accuracy of that. And in healthcare, this is a big problem, especially as it becomes more and more prolific. So now that I've kind of sent you a mixed message about how there's a lot of opportunities as well as some risk considerations, I still want to talk about what we decided to do and how we did it here at CHOP. So our current status is here on the slide on the right. We have about 10 uses of generative AI that some of them are fully in deployment, some we're still evaluating, and some we're still investigating. But this list, as I showed you earlier with Epic's roadmap, is going to continue to grow. But I'm really here to talk about our playbook. How did we go through each one of these in a standardized way to bring these opportunities to many of our users here at CHOP? Before I get there, I want to talk about how this contrasts with traditional implementation. In most software updates, whether it's something for your computer or even with an Epic upgrade, you usually get something called a release note from the vendor that tells you what are some of the changes, improvements, or even fixes that are going to come with an upcoming version. Then you build it or you install it, you implement it in some way. Usually for us, it's at an upgrade every 6 months, and then you just maintain it. If there's an issue, you fix it. Otherwise, the cycle just goes forward until there's the next upgrade. This is our current generative AI process, but this is really too busy, so I'm just going to make it very simple. We have 3 phases, and I'm going to spend time going into each of those phases. We have our discovery, our pilot, and our expansion phases. Underlying these are some core principles and frameworks. We need to make sure that the process that we have was flexible. I presented a couple of slides earlier that talked about how quickly the model layer and the application layer are changing. As such, any process that you have has to be flexible and nimble to meet those challenges. We always need to make sure that there's safety first. And so I'm going to be talking about how governance fits in, because ultimately these are technologies used in a healthcare setting, and we need to make sure that it's safe for our patients. But we also don't want to have a process that's a little bit too complicated. We still want to make progress in our process, make sure that that happens. Within each of those phases, we use PDSA cycles. If you're familiar with quality improvement frameworks, this is where this comes from, where we are planning, we're implementing it or doing it, we see how that went, and then we act on what we've learned. And that cycle happens over and over throughout the course of our pilots. So for the discovery phase, this usually is sometimes the shorter end of it. This is a couple of months where we're finding a new opportunity to implement AI. So we'll find what's out there, we'll build it, and then we'll validate it, make sure it actually works. And at the end of that, we make a decision about whether we want to move on to a pilot. So I'm going to break this down a little bit more specifically about what we've done here at CHOP. So first, we scout. We talk with Epic. We look at conferences, or sometimes the developers may even reach out to us to tell us, hey, here's a new feature that we have. Are you interested in taking this on? Then we engage with Epic. And what we do is we schedule a demo with them. We want to see firsthand, what does this feature look like? We want to know what it was intended for, what are its shortcomings, and of course, where they plan on taking this. This is the first step for us to create a really close relationship with them so that we can provide feedback to them, but also have them see more about what they should expect from clinical users using this in healthcare settings. Then, like with any team, we need to prioritize where that fits in. Early, when we had only a couple of implementations, this was fairly easy. As you get more on your plate, it becomes a little bit more challenging. Then as a team, we have a kickoff. We say, this is what we're going to do. And then internally, what we do is we make sure that we notify the appropriate areas, right? We notify our AI governance group. If we have to involve in security or legal, we let them know we've agreed upon internally what we want to do, and this is where we're going with it. And then there's something called a build validation. We need to make sure that at a basic level, when we turn this on, that it works as designed. Now, there's an important consideration that we have when we're doing these pilots is whether we're going to be pioneers or whether we're going to follow near. And oftentimes, CHOP has had the privilege of being the first to pilot several epic AI tools, which has been really exciting for us. But at other times, we've taken the stance like other hospitals to wait and see what others are doing. So here's an example of what Dayton Children's has done. They actually look to us to say, is CHOP doing it? Did it work? And if so, then they add that to their list of priorities. And we've been in both of these camps. Sometimes we've been at the forefront, sometimes we've waited for others. Now we move on to the pilot. And this is where we have a lot more review by our AI governance committee, which I'll talk about soon. We look at the data, our results, and then we have the endpoint where we say, are we ready to go forward with an expansion? So I want to talk about our AI governance committee. So AI governance review is required for every one of our pilots. So any AI that you're using now has been run through our AI governance committee. This committee was established in November of 2023, and it's representative of representatives from safety, informatics. Someone's got a mic on, legal and ethics. And really, their ultimate goal is to make sure that AI is safe, accurate, fair, and explainable. Here's just a brief example of a recent AI GC submission that I presented on for our hospital course AI. This is AI that will look through the notes of a patient's admission and provide a summary of what's happened from start to end. And this draft can be used for creating a handoff or even a discharge summary. And so what we do is we present to the AI governance committee what we're doing in terms of the security of that infrastructure, what our effectiveness metrics are going to be, how we plan to monitor for fairness or bias, what are some of the things that we do to make sure it's safe, such as making sure there's a provider in the loop, and then, if possible, can we address the issue of explainability? And for many of our AI projects that are summarizing patient information, there's citations that the user can click on to verify that the information that the AI was providing was accurate. So when we design these pilots, we start initially with a couple of really adept EHR users. We want to make sure that when we're turning it on in what's called the production environment with live patient data, that this continues to work as designed and that there's no red flags, because we don't want to bring on more users to use something and increase our risk if a couple of users could have identified that earlier on. And then we start to expand that to 10, 20, 30 users who are diverse. We want to look at different roles, different levels of usage with the system, different specialties, and so on. And as we collect more and more data and feel confident in what we're learning, that starts to expand. But we also need to make sure that we have any rollback procedures if we identify issues midstream. So here's an example of our implementation plan when we first rolled out ART. We started initially with 3 primary care sites. Then we started to stage that into adding more and more specialties. At the end, we had 13 specialties and 323 users of all types of roles to help us feel more confident that we were well represented in gathering data for this pilot. But we've also had times where during the pilot, we discovered things didn't work as well as designed. So right now, all of you have access to what's called AI Text Assistant. This is using AI within areas such as a patient message, patient instructions, or a progress note to select text and reformat it, rephrase it, fix spelling and grammar, or even to destigmatize language found in the note. When we were piloting this, one of the unintended consequences that we discovered was that in a lot of our notes, we save data behind the scenes for quality improvement, research, or even clinical decision support. And the technical name are called smart data elements. So behind the scenes, when you make certain selections, we save that data and it flows somewhere else. AI Text Assistant essentially scrubs this data if you were running the Text Assistant on that. So we reached out to Epic and they didn't have a solution for us. So in our plan where we decide, are we ready to move forward? We said, no, we're not ready to move forward with this. We're just going to wait for a new feature. And about 6 months later, Epic reached out to us and said, hey, we fixed the issue. We will not allow the AI text assistant to run on sections of that text that save data, because we want to make sure that all the effort that we put in to get that data into the system and to flow to other places isn't lost. And then we proceeded. We also need to make sure that pediatric specific considerations are implemented into these pilots, because oftentimes you may find that Epic hasn't really considered that. So for example, early on, we had given them feedback that the drafts that are done for the in-basket or for other areas need to consider the audience. We're not just working with the patient, we're often working with the patient and then a caregiver. So one of the upcoming features for the text assistant for patient instructions is going to have an explicit button that allows you to write patient instructions for the patient, who may be an adolescent, or for the caregiver. We also want to make sure that LLMs have confidentiality settings too. When we first were piloting ART, one of the first questions that we had was, is it possible for the LLM to disclose private information about an adolescent to their parents? We tested this, we worked with Epic, and we discovered, nope, the way they had built this had the guardrails, so it wouldn't inadvertently release something from an adolescent's private labs, for instance, into a message responding to their caregivers. You're also seeing that in other areas, Epic will flag the user if there is information in a draft that the patient doesn't have access to. So if you were writing a draft, a discharge summary with AI, and if it pulls in a note that is not available for viewing on MyChop, it will let the user know that, so that they also are considerate about whether they include that in their draft, because you may unintentionally disclose things by having the AI have looked into that and then drafting that for you. So again, this is where it's really important to double check what you're seeing from the AI before you sign those notes. Let me take a drink real quick. So let's talk about piloting data. There's a number of ways to gather data, and some of them are going to be quantitative. You'll sometimes be able to get information such as how often people are using it, who's using it, how much time you're saving users, are they closing their charts in a more timely fashion. You're also looking at some qualitative ways. We use tools like RedCap to help us gather information in surveys. Sometimes we've done interviews or focus groups. Epic has often built in tools into their existing AI tools that allow you to give feedback from within that activity itself. So you'll see this in the chart summaries in the in-basket. If you click a button, you can give our team positive or negative feedback. But you really want to be thinking about multiple ways to get that same data. In one of our pilots, we did do a usability study. So what this was is this was for a pilot of the inpatient version of a chart summary. So essentially what the AI is able to do is to look through a host of data during a patient's admission and to give you a general story of what the patient has been experiencing, as well as any recent events. So we did a usability framework study to look at that. We recruited about 10 physicians, we had facilitators, we had specific tasks that they wanted them to do, and we interviewed them while they were performing those tasks. And we used tools that we already had readily available to us. We used what's called our Epic support environment, which is a copy of production, which allowed users to have real access to patient data, patients that they were seeing during this usability study. We use Microsoft Teams to schedule and record the meetings virtually, and then we use RedCap for those for the feedback. While you're doing your pilot, you need to have really clear success criteria, but that's going to differ for each feature. you can't actually use the same criteria over and over again because they're so different in the way that they're designed and what the benefits are for those features. So you may be looking for things like improved efficiency, saving time, or positive user satisfaction, or all of the above. But it's really important that across all of those, that we are looking for whether we've identified any safety issues. So now I'm going to give some examples of data from some of our pilots. For in-basket art, we are finding on average that the drafts were saving users 25 seconds in comparison to when they weren't using the AI drafts. For the note summaries, we're finding that it was saving 16 minutes per chart review. What that means is if you were to have a human read through every one of the notes that the AI was able to read in, about 20 seconds, this would be about a 16-minute difference. About a quarter of our participants were telling us that they had found information in the summaries that they would have missed otherwise. And we were looking at our usage data, and early on, we were finding that there were thousands of these summaries being generated weekly. And then in our ambient scribe pilot, we were finding that 37% of users were closing their charts faster. And we also did a pre and post assessment of burnout, and scores on burnout dropped by 54%, which is really exciting. Now you've done the pilot, you're ready to move to the expansion phase. And this can take, several months or more, depending on the scope of that. But what we're really doing is designing a ramp-up plan and how we're going to monitor after we go live at a bigger scale. We're going to get AI governance approval, like I've talked about earlier. Then eventually we're going to execute that. Really, we're going to make it available to users in a smaller area or a bigger area. And then eventually that product is going to get transferred to operations. So when we go to AI governance for that expansion phase, we're giving them an updated summary of what the feature is, as well as the results from the pilot phase. And depending on the feature, there may be more of an extensive review because now you're going from something that's affecting a small number of users to sometimes the whole enterprise. And we really want to make it clear that none of these features get made widely available without the governance sign-off. Pop up on my screen here. Okay. So once you decide that you're going to go forward, you need to, of course, make sure you have robust ways of tracking usage, feedback, and quality via things like reports and dashboards. We do have ongoing safety reviews, and so information that is given to us from the feedback that you, the users, are giving to us, we actually have a weekly quality and assurance group that is looking at that feedback and deciding if there's issues in there that we need to escalate to Epic, or things that we can modify, or things that we need to bake into future training about how to help users understand the limitations of AI. Here's an example of one of the dashboards that we get from Epic. So these are pre-made by them. And this is an example for the ART in basket that lets us trend over time, how many users are using it. We even get information such as the time savings and much, much more. But there are times where we don't get the data that we need because either Epic hasn't made it easily available or we had to do something a little bit custom. So here's an example of a dashboard that I built that helps us more easily review some of the feedback data that we get on summaries. So what this does is when a user says that they have a concern about a summary that they've gotten, we take that file and we put it into a dashboard that lets us see exactly what you saw from the AI, but it also brings in all of the notes that the AI summarized for that. That lets us validate your concern and say, you know what, we found the same error from the AI as well, or here's maybe a misinterpretation based on what we're seeing. But it allows us to really recreate that scenario that you experienced when you gave the feedback. So now it's time to pat ourselves on the back and talk about what we got right. Now, I'm going to frame this from an interesting metaphor. My wife and I have just started watching The Bear. We're late to the game, but it is an incredible show. And because I was watching the show while I was preparing for this, I decided to bake that into how I talked about these next two slides. Like any good restaurant, it's really important to know your growers. Know where sourcing their food, know who's behind that. And it's the same thing with the work that we were doing. It was important for us to know the developers and their intentions behind that, and to develop those really close working relationships so that we can give feedback and raise and escalate those concerns quickly if there were any issues. Of course, you want to staff your kitchen well. You want to make sure you have the right staff. And we have a great multidisciplinary team of people from many roles that are involved in these projects so that we have a well-represented set of eyes and experience levels to help us implement these really well. Of course, you want to get that A inspection sticker on the front window of your restaurant. And this is why from each of those phases, we have built-in governance to make sure we're safe among every stage of that process. And every good cook knows you taste your food before you serve it. And this is where those PDSA cycles go in. For every stage, we're assessing how well is this going before we get to the end and we're ready to expand. But not everything goes well. What we started to learn later on is we were overloading the menu. At times, because of the pace of the change and the number of features that Epic was implementing, we had to really step back and say, is this more than we can handle? So now we're in the phase of doing more of monitoring our resources and really prioritizing what we can and can't do based on what we have. You got to know your regulars, right? Know those customers who come in frequently, what they like to order, what they don't like to order. And start to question with these AI implementations, is this AI right for everyone? And there were times where we initially thought the AI was right for certain roles, and then we later discovered it was actually better for others. But we didn't really know our customers, and now we have a better understanding of understanding who is this designed for. But sometimes you'll be pleasantly surprised that new customers end up liking it differently than you expected. Training is super important, and the pace at which AI has been developing was really outpacing the ability to train everyone effectively on that. And so for anything, AI competency should not be an afterthought. And so I do want to make a plug for Data and Analytics' School of AI. This is a great program which is offering workshops and resources for all of our users here at CHOP to learn more about how to use AI effectively. And not just Epic AI, Copilot and other features there. If you type in School of AI in the SharePoint, you'll be able to easily find that. And finally, we know that winging it or eyeballing your recipe is a recipe for disaster. And we often found that early on, what was really challenging is we weren't getting enough sufficient data from Epic to be able to monitor and evaluate it to the degree that we wanted to. And so we've started to put a lot more pressure on the vendor to give us that data early in the pilot so that we have that throughout instead of waiting until the end to have that. So finally, I want to wrap it up with some takeaways. Generative AI is here. It's really about the question about how we manage it. In our playbook, it was really important to be flexible. We wanted to be fast enough to give you the benefits, but we also needed to be slow enough to make sure it was safe. Governance is a resource. As you saw, they were in every stage there. And not only are they reviewing it to make sure it's safe, but they're also providing a lot of guidance on how we can do better with how we implement that. And we found that for us, starting small and learning fast and scaling with data was really one of the key things that helped us to get ahead of all of these. So finally, I want to talk about what this means for you. As a clinician, if you are one, please review the AI drafts and AI summaries. I talked about some of the risk of AI, its ability to confabulate or make mistakes. It's still important for you to review these things. Do not fall into an automation bias. Adding on to that, keep a critical eye. The AI sounds very plausible, but I want you to have that practice with a questioning attitude. And give us feedback on all of these AI tools. At the very bottom, you'll see a thumbs up or thumbs down. Give us feedback if there are issues. We do review them. Now, you at times will be a patient in a healthcare system, or a family member will see a provider at a healthcare system that is using AI. Keep in mind that Interestingly, AI can sometimes be used as a way to reduce reliance on technology and increase quality time with your care team. It's important for us to always make sure that we keep a human in the loop for many of these workflows to ensure that the AI doesn't make any mistakes that may affect patients. And ultimately, it's really okay to ask about AI. If you're in a visit and your physician is planning on using an ambient scribe and they don't tell you about it, or they don't tell you about what your rights are about that, it's okay to bring that up. This is new across healthcare, and having that transparency about when it's being used and how that organization is protecting their data or consenting families is really important. So that's all. I want to make sure that I leave some time for questions. Thank you for attending this talk. And if you do want to reach out to me, there's my email. Also, if you'd like to follow me on LinkedIn, where I provide a lot of the updates on what we're doing here at Chop with AI, as well as just my general thoughts about AI, feel free to follow me.
Thank you, Stephon. That was really an excellent presentation. You're doing just amazing work. Lots of people at CHOP are doing amazing work, and thank you for leading those efforts. There is a lot of activity in the chat. I will try to summarize some of it, but maybe we can also try to get back in some way, to some of these questions through other modalities. There are links to the AI school School of AI that Stephon mentioned. I think maybe just first to a lot of folks really interested in how can they participate? How can they kind of get involved in some of the pilot activities, et cetera. There's some, even more specific questions about even things like, oh, when are we going to get, AI features in the ICUs, ambient scribes, et cetera there. So, just didn't know if you can tell us of some of that, as
Yep.
well as some of the timelines for
Yeah.
things that are coming up.
So in terms of getting involved, depending on the project, there are often times where we're putting out open announcements to anyone who's interested in that. We do that very sparingly because, again, these technologies are very early. So we often start with super users, informaticists, people who have already been in roles where they're usually on kind of the bleeding edge or have a higher level of Epic expertise. We could get better at recruiting more participants. So I think that's helpful feedback for us to see if we can find ways to, query you as users to see if, hey, I would like to be a person that can be in a future AI pilot. I am looking at the chat here. I think
Yeah.
some of them are being answered.
Yeah, Bimal and Eric and others are answering
Thanks.
some of the questions, so thank you all for doing that. I think there may be a couple of questions related to patients. What kind of disclosure, and
Yep.
involvement, I guess, in terms of patients and families about the use of AI.
Yep.
Also, in terms of, patients' feedback, have we gotten any, in that regard?
So in terms of disclosures, we did update our terms and conditions for MyChart to include language about our use of AI there. For the pilot that we did for a bridge, where we were using the ambient scribes, we worked with legal to come up with very clear consent language that we make sure we get verbal consent, and then we actually document that into the chart so that we get permission from everyone in the room. So even if someone signed the consent form at the front desk, we still need everyone in the room's permission before we do that. The field is still discussing how more broadly we talk about AI, because at some point, AI will be used in so many different workflows, it would almost be impractical to go through and list all of the iterations on that. In the same ways, we don't tell families that we're using clinical decision support tools like BPAs or OPAs. So we are exploring that. Some of that is also looking at legislation that says what we should be doing. So more on that. Let's see. Patient feedback. We did ask about patient feedback during our ambient AI pilot, and we got a lot of positive response to that some of the feedback was that families felt like the clinicians were a lot more engaged with them and had more time to explain what they were talking about, because there's two factors. One, you often had more time because the AI was doing some of the work for you. But to make the ambient scribe really effective, it's really important that we as clinicians speak out loud what we're thinking and also use words that families can understand. And that created this side effect of transparency, because now, because I'm talking for the AI, I'm also talking for the family. They were all part of that conversation, which is really exciting to hear.
Uh, Kevin asks about diffusion of innovation, kind of addressing the risk of leaving some people behind or not getting minority opinions into the improvement cycles early, et cetera. Also, I was curious about how you do monitor for, any kind of bias. It seems like you have really good processes in place for
Yeah.
validating, the accuracy of notes, et cetera, but bias and as some of the other points that Kevin is bringing up.
Bias is one of the trickier ones. And so one of the challenges that I was sort of kind of in tuning is that there's the model and then there's the application. And because what we are interfacing with is the application, a lot of that programming and all of those settings behind the scenes, we don't have direct access to. And so, whereas if you were to design your own LLM model, you can directly measure it. I think the analogy is sort of like taking a car for a test drive, but not being able to open the engine by any means. You just the dealership won't let you look at under the hood about how it works. So you just have to go based on your experience in your feel. This is why it's really important during those pilot phases that we encourage users to give us feedback to let us know if they're picking up on any of those things, such as biases. Another challenge is that the AI is different for every patient at different times. And so every time it is being used to summarize a note or a patient interaction, it's unique to that instance. And so it's really hard to systematically look for the same types of biases because every presentation is unique.
I think there are several questions about the configurability, of the functionality.
I'd say in general, there's not much configurability. If you've
Okay.
ever worked with Epic in general, there's not much configurability
Yes.
unless they say you have configurability. And the same is true with a lot of these. Unfortunately, for many of these, you get what you get, which is really important for us to oftentimes prioritize being at the forefront of these, because we're getting in at the R&D level. And a lot of the changes that we've seen at CHOP were because we were there early and were able to tell our developers what works and what doesn't work. So in a way, we were customizing it by being involved during the creation of these technologies.
That's great. A couple of questions about the financial aspects of all of this. How much does it cost? And I guess, are there any cost savings? Are we able to kind of demonstrate that at this point?
I'm not going to go into specifics about the actual cost. I really wanted to keep this more on kind of the work that we're doing, but there is still research, and we're going to plan on continuing to evaluate. We had a very limited pilot that didn't have robust enough means to look at things like the financial, like revenue generations. But that is something that we're looking to be able to have a better infrastructure for measuring going forward.
Interesting question about, I'm just kind of picking and choosing. And please, if anyone wishes, they really are passionate about your question. If you wish to kind of ask Stephon directly, please just raise your hand and, unmute yourself and we can have you ask. Does Epic use CHOP data to improve their LLM, for example, retraining?
Good question.
Yeah, what are,
no, so it
where
does
is our
not.
data going?
It actually doesn't. And so there's two aspects, right? Epic is using Microsoft, which is using OpenAI. So there's all these layers here, and we've made sure that even from the outset when we're signing these contracts, that our data is not being used to retrain. Now, does Epic take our feedback to improve their product? Yes, but that's very different than taking the patient data and retraining on that. So OpenAI doesn't have access to our patient's data to make GPT-6, for instance. It's a really important question. And CHOP is that's a high priority for us to make sure that with any vendor that we are establishing those boundaries of where our data ends and where their training begins.
Well, I know we're at the top of the hour. Stephon, I know you've been scanning the chat too. Any other final comments or questions that you'd like to address?
No, I mean, we do have a SharePoint that, thank you, Bimal, for posting that there.
Yeah.
And that SharePoint site will start to grow as we have a lot more of these AI products onto that. So I would say follow that. And it's an exciting time. And so stay tuned for a lot more of these features coming your way.
Great. Thanks so much, Stephon. We really appreciate this amazing talk and all the amazing work you're doing. We had almost 200 participants today, which I think is a record. We are recording this session. Again, if you're interested in CME, the details are in the chat, and you have until 1:15 to claim that. And again, thank you again. And I'm sure we all will be in touch, as I think many of us really do want to work with you and in this exciting space. So thank you again.
Welcome. Bye, everyone.